Welcome to this weekly webinars organized by Saudi Society of Blood and Marrow Transplantation. Today we are going to have an excellent presentation and excellent speaker. It's going to be about how I treat mantle cell lymphoma in light of new EHA and I-ICML update. The speaker is Dr. Christian Busek, who is a prof of hematology, and he's medical director at Institute of Experimental Cancer Research, University Hospital Ulam. He's a senior consultant, Department of Internal Medicine, University Hospital Ulam. He has many publications in peer-reviewed journals. He is a member of many committees, and he is the founder and coordinator of the European Consortium of Blood and Storm Macroglobulinemia. He is the president of German Lymphoma Alliance, and he's editorial board of journals of leukemia and cancer. His scientific focus is in low-grade lymphomas, including Waldenstrom macroglobulinemia, marginal zone lymphoma, follicular lymphoma, mantle cell lymphoma, and acute leukemia. This tonight webinar is sponsored by Janssen, and we would like to thank their contribution to our webinars. Without any further delay, we'll hand the microphone to Dr. Christian.
Yeah,
Doctor, you can start.
Yes, thanks a lot. So it's really a pleasure to be again with you and to discuss with you now this time mantle cell lymphoma. And as also told last time, it's an exciting time for all these B-cell lymphomas, in particular Waldenstrom mantle cell lymphoma, but also follicular lymphoma. And we will hear exciting news for diffuse large B-cell lymphoma at this year's ASH with practice-changing results, which we only know by press releases. So in total, it's really a great time for our patients as we really move forward. So the focus today is mantle cell lymphoma, and I would like to go with you through the newest developments, but also that we go one step back and look at mantle cell lymphoma a little bit more in a general way. So these are data actually from 2015, and you see here the prognosis of the different B-cell lymphomas, and as illustrated here, it's quite devastating from the perspective of mantle cell lymphoma. So it's not a publication 30, 40 years ago, but you see mantle cell lymphoma is still a very bad disease, in particular when you compare it to other indolent lymphomas, follicular lymphoma, marginal zone lymphoma. But even when you look at diffuse large B-cell lymphoma, where you have a certain plateau and of course some curative possibilities, so mantle cell lymphoma is really still an unmet medical need. I think we have to be aware of this when we discuss how to manage our patients. So just to re-summarize disease characteristics of mantle cell lymphoma. So first, I think we have to keep in mind mantle cell lymphoma is in itself heterogeneous. It's a heterogeneous disease. And this is reflected actually by its clinical behavior. So we'll come back to this in a second. We have very indolent cases, but we have also very aggressive cases. It's also reflected by the histology, where we have classical small, but also pleomorphic and even blastoid pictures, which correlate also when you look at blastoids with the clinical course. So, and this actually in some way also leads to a contradiction when we look at mantle cell lymphoma, because for the vast majority, when we take out the blastoid version, mantle cell lymphoma looks like an indolent disease, and this is why actually mantle cell lymphoma initially was described and categorized as an indolent lymphoma, as a centrocytic lymphoma. So this was the old name by the so-called Kiel classification, which was very famous. It was the first to categorize lymphomas according to morphology and in some way biology also already at that time. And just that you know, Kiel is a city in northern Germany and was very famous for lymphoma histology at that time, 20, 30 years ago. So mantle cell lymphoma is predominantly male, so male gender is over 70%. And it's, as the other B-cell lymphomas, a lymphoma of the advanced age. You see bone marrow involvement is very often the case, stage 4, and extranodal manifestation also is very typical for this disease with around 80%. So as said, mantle cell lymphoma is very heterogeneous, and we know that we have mantle cell lymphomas where we have to treat. So this is shown in the in the upper part of the slide with classical mantle cell lymphoma or blasted mantle cell lymphoma. But we also have here in the lower part the so-called leukemic non-nodal mantle cell lymphoma, which clinically behaves more like a smoldering disease. So when we then look and do the separation in a vertical line, we see that when we look at patients who need treatment, that we can distinguish between classical mantle cell lymphoma and the blastoid variant, which is associated with a poor prognosis and also with genetic markers which are predicting poor prognosis, such as p53 mutation. So when we look at mantle cell lymphoma and its prognostic features, what we can keep in mind is that around 1/3 of patients actually belong to the high-risk group, 2/3 to the intermediate and low group. And we have in mantle cell lymphoma quite good possibilities or tools to actually categorize our patients into different risk groups. And one of the major determinants of prognosis are p53 mutation, the expression of positivity for Ki67, the proliferative marker, or as already mentioned, the blastoid morphology. And this has a direct impact on the treatment outcome of patients with mantle cell lymphoma. These are mantle cell lymphoma, younger, elderly, mixed. And you see when you have a high-risk disease shown here in green, your median for overall survival is very short, as illustrated here, 2.2 years versus 6.3 years. And the same is also true when you look at the progression-free survival. So as said, we have high-risk markers. This is p53 mutation, loss mutation, or overexpression by immunohistochemistry. And p53 is indicative for an unstable genome, if you like so. So these patients are enriched for complex karyotype or mutations in very important signal transduction proteins or genes such as Notch1 or ATM. So classically, they have an inferior response to chemotherapy, and they have also, we will see this later, an inferior response to BTK inhibitors. So, and this is also illustrated here in this publication that always shown in blue, the p53 mutations, that you indeed have difficulties to get these patients into remission when they are offered even intensive immunochemotherapy. So what we do is we use the MIPI. I don't know whether this is also done in your country. The MIPI, which actually is based on clinical parameters such as ECOG or age. And then we add biological markers such as Ki67 and have as a threshold this 30%. And then we are able to subdivide our patients in low risk, low intermediate, and high risk patients. So it's a very good tool, and in the websites or in the internet or on websites, there are also a lot of possibilities or tools to calculate the MIPI when you put in the parameters needed for the MIPI. So this is just some contemplation about the heterogeneity of mantle cell lymphoma, so the underlying biology. And this leads us now to the clinical management. And this is just an overview about different treatment categories. And you see it's, again, it's a whole panel or plethora of treatment options ranging from watch and wait even. Yeah, indeed, we do watch and wait in mantle cell lymphoma, up to very intensified chemotherapy, transplantation, or more targeted treatments, such as, of course, BTK inhibitors, immunomodulation, Benito Clutch inhibitors. So that's really amazing. So we have a lot of different tools. Yeah, and this is for sure a positive aspect when we think about mantle cell lymphoma. But of course, based on this, it's also complex to find the right clinical management. So we do indeed watch and wait. I would like to start with this. Watch and wait is an appropriate approach for patients with a smoldering mantle cell lymphoma. So how do we define smoldering mantle cell lymphoma? To the end, we define it by our clinical experience with these patients. But they have, so, you know, when they behave clinically very indolent, I think this is the final proof that you really deal with a smoldering mantle cell lymphoma. But as illustrated here in the table, you have some differences with regard to lab values or genetics or immunophenotype. So the classical mantle cell lymphoma, which behaves aggressive and needs treatment, is, for instance, when you go through, has a higher Ki67, has a lower MIPI. I think we talked already about this. So it's more often an elevated LDH. It has more, more bulky disease. SUV is higher. And you see also here with the genetics that you have a higher proportion of patients with unfavorable genetics, such as P53 mutation or cyclin D1 expression levels, similar expression levels. And there are even certain differences in the immunophenotype, such as CD5 expression, which is classically low in the smoldering mantle cell lymphoma, in contrast to classical mantle cell lymphoma. So there is this group of patients, and the appropriate management is indeed watch and wait. But of course, by far the majority of patients belong to the classical mantle cell lymphoma or even to the blastoid version. And this just shows you an overview about some kind of therapeutic algorithms we are using in Germany, but also in the European Consortium for mantle cell lymphoma. And you see we differentiate between younger patients and more elderly patients. Of course, this is very artificial, 65 the threshold, but you have to draw the line somewhere. And when we focus first on the young patients, we see what is our standard at the moment. It's RRC containing induction, and we use autologous stem cell transplantation plus rituximab maintenance. So this is our standard, which we are still using today, despite all these new exciting drugs. So why RRC containing regimens? Because the European Consortium did a large randomized phase 3 study where in the induction, they compared actually CHOP versus CHOP alternating with DHAP. And as illustrated here, so this was published 5 years ago, the RRC containing regimen, RDHAP, was significantly superior with regard to the time to treatment failure, so a clear advantage. So this was actually based, this large phase 3 trial, on early phase 2 data from the French group, and the French group then went one step further because they tried to understand how to further improve RRC-based induction. So they treated the patients again with DHAP, 4 cycles DHAP, and only the patients who were not in complete remission got 6 cycles, then they added CHOP. Then they did an autologous stem cell transplantation followed by rituximab maintenance. And this was published very high in the New England Journal because it changed our standard in the sense that, as shown in this treatment algorithm slide, that we see rituximab maintenance as standard after autologous stem cell transplantation in treatment-naive younger patients. And you see this was not only the event-free survival, progression-free survival, but also there was a significant difference in overall survival. So patients with mantle cell lymphoma live longer with autologous stem cell transplantation plus rituximab maintenance. So when we now go for the elderly patients above 65, so what is our standard there? You use conventional immunochemotherapy still, and you have different possibilities. You can use R-CHOP, you can use bendamustine rituximab, you can use rituximab bendamustine, here RRC containing cyclophosphamide, the R-BACA regimen, or there is one regimen which is a little bit more dose intense, VRcap, which is, I have the slides with me, I think, which is very effective, but a little bit more toxic when we compare it to R-CHOP. And rituximab maintenance also is standard for the elderly patients with mantle cell lymphoma. So the first question is why CHOP and perhaps not fludarabine cyclophosphamide. This was again a randomized study from the European Consortium for Mantle Cell Lymphoma, also published at that time very high because it proved that R-CHOP is one of our standard induction regimens for elderly patients with mantle cell lymphoma. So you see there was a one-to-one randomization of this treatment-naive elderly patients between RFC and R-CHOP. And then there was a second randomization, rituximab maintenance versus interferon alpha. And who was the winner? It was R-CHOP and it was rituximab maintenance. So this is why R-CHOP followed by rituximab maintenance is one standard based on this large randomized phase 3 trial. So, and this was updated. You see, this is a JCO publication of the same study, now with a longer follow-up. And as illustrated here, what you see is that actually the failure-free survival, so RFC is quite good. So it's a very effective regimen. But when you look at overall survival, you see R-CHOP is better. And this is because RFC is too toxic. So we had more treatment-related mortality with RFC, and many of the patients in the fludarabine arm were not able to get the full number of cycles. So this is why R-CHOP. Why then VRcap? This was again a very nice study, also published in the New England Journal. Again, treatment-naive mantle cell lymphoma patients, randomization 1-to-1. What you see here, the classical R-CHOP, which we just said is our standard compared to compared to RFC. And you see here the experimental arm, which adds bortezomib. Here to the CAP regimen, which has no vincristine anymore because you are concerned with regard to neurotoxicity. So I go one back. So no rituximab maintenance in this study because it was not established at that time. But what was seen in New England Journal publication, that the progression-free survival was significantly better for VRcap. And in the later update published in Lancet Oncology 2 years ago, there was also documented a significant improvement even in overall survival. So you could argue, why then not giving VRcap to all patients? But as said, it's more toxic than R-CHOP. So when you have a young, an elderly, biologically young patient, fit patient, VRcap might be a very good option to treat such patients. So what about bendamustine, which is very popular in Germany? It's an old East German drug developed by the communist part of Germany, actually, a long time ago in the 60s, as an alternative to adriamycin. And there was this randomized phase 3 trial. Actually, it was a phase 2 trial, which is important to keep in mind, which showed that bendamustine rituximab is at least as potent as R-CHOP. So here there was even a significant superiority when you compare BR to R-CHOP. And you see here highly significant. So we are a little bit cautious, but at least we are sure that bendamustine rituximab is not worse than R-CHOP. I think both are very powerful. So this is a randomized trial, and these are real-world data. It's a little bit small, but what you see, it's true. BR, here followed by maintenance, is very efficient. R-CHOP followed by M by maintenance rituximab, so orange and blue. So bendamustine is really very efficient. And so this is progression-free survival, and you see overall survival. There's no difference between bendamustine and rituximab. But this real-world data are important also because of another aspect, because there was a lot of discussion whether you should give maintenance rituximab also after bendamustine rituximab or only after R-CHOP. But you see that maintenance makes sense also after bendamustine rituximab following this real-world data. So these are the data without maintenance. And you see also from the overall survival that without maintenance, you have a shorter overall survival compared to maintenance. So very clear our standard rituximab maintenance in the elderly patients. So this is also, again, categorized here. So what are we doing? We do induction and maintenance in the elderly. We do induction, autologous stem cell transplantation plus maintenance in the younger patients with mantle cell lymphoma. Again, when we follow mantle cell lymphoma, and this is the study now I already showed you, R-CHOP versus RFC, and the second randomization was rituximab versus interferon alpha. This is shown for R-CHOP. And you see rituximab followed by R-CHOP is much better than rituximab CHOP. Rituximab CHOP followed by rituximab is much better than rituximab CHOP followed by interferon. With regard to PFS, you see the same for FC. But when you go to overall survival, again, rituximab CHOP followed by rituximab has the best overall survival. And here you see the detrimental effect of the toxicity of fludarabine on the overall survival. Again, this is why we actually lost RFC as standard. And here now a little bit better to see the maintenance, the same data I showed you before. Maintenance is our standard here for progression-free survival and for overall survival. So this is where we are standing when we go back and when we look at our treatment guidelines. So because all these new approaches, they will change dramatically our treatment landscape. Absolutely correct. But when you treat now, today, a patient with mantle cell lymphoma, I think it's still very important to know the data I showed you. And I think it's also important to know these data because all the new approaches have, of course, to beat the very efficient immunochemotherapy followed by autologous stem cell transplantation followed by rituximab maintenance. So it's already a very effective approach, and we have to see how efficient these new drugs are, in particular in randomized phase 3 trials. So now new approaches. Of course, our dream is to get rid of chemotherapy, to work with targeted treatments. And there are very good ideas and very good combinations with high efficiency in mantle cell lymphoma. So the first one I would like to introduce is lenalidomide rituximab. As illustrated here, you give lenalidomide 3 weeks and 4 weeks cycle until progression of disease. And you add rituximab here 4 weekly, and then in these 2 month intervals. These were a smaller study, highly published in the New England Journal, because at that time, it was the first proof that you can, without chemotherapy, you can offer patients a quite well-tolerated chemotherapy-free approach. You see 38 patients between 42 and 86 years, and the progression-free survival. So the median, these are years from treatment. The median not reach over 7 years, 60%. So very good data, but of course we have to be cautious. These were, I would say, a low-risk profile mantle cell lymphoma patient cohort, but for this low-risk patient cohort, lenalidomide rituximab is very interesting. So next idea, you keep rituximab, but you don't add lenalidomide, but you add ibrutinib. And this was just presented here at the ICML this last summer. Again, the idea very similar, 4-weekly infusions. So you saturate your patient with an anti-CD20 antibody, and then you add in a limited form 4 infusions of rituximab, and then you give ibrutinib for 2 years. And I think this is also really a great idea. And you stop ibrutinib if these patients are MRD negative. There was also MRD measurements. There was PET-CT by central review. So a very nice study, I think important. Again, you see low-risk patients, asymptomatic patients, ECOG 0 to 1, leukemic non-nodal forms, or when they have nodal forms, not more than 3 centimeter, Ki67, smaller than 30%. So a very good prognosis patient cohort. We have to keep this in mind. You see actively patients were excluded with blastic or pleomorphic variants or larger lymph nodes or higher Ki67 positivity. But nevertheless, it's a very mild treatment. You have a treatment where you stop, or you have the possibility to stop ibrutinib. And these are the first data. The follow-up is still short, but you see here that actually overall survival, but also the PFS is quite dramatic. So it's around 80% after 4 years. And it seems to be that it's possible, at least in a part of patients, to stop treatment per protocol. In 19 patients was this the case. And from these 19 patients, 3 converted to MRD positivity again. Yeah, I think a very nice approach, but we have to see with longer follow-up how we can deal with this. But you see the concept behind. When you have low-risk mantle cell lymphoma, the clear-cut idea is omit chemotherapy and work with targeted treatments. So this is, again, the same study. We can focus now here on the response rate, which was not shown in the former slide. Complete remissions, 80%. It's really great. Over 80% overall response. And you see here the MRD negativity, which in patients who achieved complete remission, and remember, these were 80%. The majority of patients receives complete remissions. And from these patients receiving complete remissions, 70% become MRD negative. And this is not Benito Clutch, this is ibrutinib, so a drug which is known not to be so powerful in eradicating disease. So these are very nice ideas for the low risk and patients with mantle cell lymphoma. But of course, first, we don't have, of course, always these very good prognosis patients. And secondly, we need randomized trials. And you see here the concept, which is, of course, very intriguing, but still conservative. So you have untreated, non-transplant eligible or scheduled patients. So it's not for the elderly patients. Double-blind, phase 3, so a very important trial. And you see here the standard are bendamustine followed by rituximab maintenance. We discussed this before. And you see the experimental arm. So it's a cautious study because the study does not dare to take away bendamustine. So you keep the chemotherapy, but you add ibrutinib until progression. So we are waiting a long, long time for this data, and we hoped year for year that you would get a result. But this year's ASH, I think we will hear the data, and we are very curious what we will see. And of course, we anticipate that ibrutinib will make a clear difference. But let's see. Yeah, so a very important trial called SHINE. So this study, again, a randomized phase 3, it's a so-called triangle study. It's an academic study of our European Consortium for Mantle Cell Lymphoma. Now you see transplant eligible. So it also comprises high-risk patients, younger patients. And the concept is a little bit similar. First, you see our standard, which we discussed, CHOP-DHAP, autologous stem cell transplantation, and rituximab maintenance. So forget the observation arm. This was when the study was initiated, but when rituximab maintenance became standard, all the patients now get rituximab maintenance. Then are coming the two experimental arms. The first arm actually also does not dare to take away chemotherapy, because autologous stem cell transplantation is nothing else than highly dosed, intense chemotherapy. So all patients get autologous stem cell transplantation in first remission, but they get, in addition to rituximab maintenance, ibrutinib for 2 years. The third arm is probably the most exciting one, because this arm has most courage, because now what you see is the hypothesis is that you don't need autologous stem cell transplantation anymore. Our standard here, rituximab maintenance, but you just give 2 years ibrutinib maintenance, and even although the patients are young and transplant eligible, you don't do it anymore. It's a very large trial in 14 countries, over 800 patients. You know, mantle cell lymphoma is not that frequent, and you see that within these European consortia, whether it's Waldenström or mantle cell lymphoma, you are able to do very large trials, and this trial is fully recruited, but we will still need 2 to 3 years to get the results. So what else are the concepts? So here now, again, a randomized phase 3. Now for the elderly patients, again, academic, again, European Consortium for Waldenström. The standard was R-CHOP, but you see here that we also try now in the elderly patients to give RRC, not 3 grams, but 1 gram per square meter, so dose reduced. And you see here that we try to improve in the second randomization, the rituximab maintenance. And I showed you before the single-arm phase 2 study, which were published in the New England Journal, which showed that R-square, rituximab plus lenalidomide, is highly efficient. So why not taking R-square instead of rituximab maintenance as a new maintenance concept? So and also this study, we still do not have data, but it nicely shows you how these new ideas are built in randomized phase 3 trials. So this just gives you an overview about the trials which are running, SHINE, addition of ibrutinib beneficial, then the so-called ENRICH study. I didn't mention this, very similar to the SHINE, with the difference that you take out bendamustine. So chemo-free as good as chemoimmunotherapy. So take out benda. And now the elderly 3 study, which I also didn't show you before, which is the newest study, which we will do again in the European Consortium. This goes one step even more forward, because it does not ask anymore whether chemo-free is better than immunochemotherapy. It's already trying to optimize chemo-free approaches. So this is the road we will go when you look at the MCL 3 study. So in contrast to the study I showed you before, the 2 study, no chemo anymore. Yeah, and as emphasized before, so all these studies are for untreated, non-transplant eligible patients. And here the movement is very clear towards a chemotherapy-free approach, as shown here below. So what else do we do as concepts, as study concepts in the future? And I think this is also a very exciting study. It's an academic study, again, from the European Consortium. So when you have high-risk patients with the blastoid variant, high P67, we know that they have difficulties even with the standard approaches, autologous stem cell transplantation we have. So the idea here is that in these very high-risk patients, that you do CAR T cells, this is a kite product, first line, not in the relapse. So you do R-CHOP, RHAD, leukapheresis, and then you conditioning with fludarabine cyclo, and then you give CAR T cells. And this is followed actually by rituximab maintenance, a very aggressive approach. So the study has not started, but will start first quarter next year. So another idea is, we saw that ibrutinib was combined with rituximab. And the other idea is that you take ibrutinib, that you take an optimized anti-CD20 antibody with obinutuzumab, plus that you add Benito Clutch. So this is the so-called OASIS trial. It's a single-arm phase 2 study from the French study group. And it's treatment naive, but this is not for low-risk mantle cell lymphoma. So, but just for, let's say, normal patients with mantle cell lymphoma. So also including classical and even not excluding blastoid patients. So a very low number of patients so far, but from 15 patients treated, 14 patients remained in CR and are under treatment. This is shown here, the PFS, the overall survival. So illustrating again that without chemotherapy, treatment naive, and with a normal risk profile, as a proof of principle study, early data for sure, that you are able to get these patients in long PFS and the vast majority of patients in a complete remission. So these are very interesting data. So this is, again, the slide I showed you before. So we have different tools as I showed you. So, and future standards may become more risk profile based. So with the idea when we have elderly patients, non-transplant eligible, or even younger patients with a very low risk profile, that you go chemotherapy free, as I showed you. Whereas when you have high-risk patients transplant eligible, that you, let's see the triangle study, that you do not omit immunochemotherapy induction, but that you can perhaps omit autologous stem cell transplantation. And then when you have ultra risk, very high risk patients, that perhaps even CAR T cells first line are a standard option. So this is first line. What about relapse? So we know from mantle cell lymphoma, as for all other B-cell lymphomas, that we have a tremendous difficulty when we go into later lines of treatment, and that the overall survival really decreases one by one, as illustrated here on the left side. And the same for progression-free survival. See, it becomes very short already in the second line setting. So relapse patients, a major problem. So what can you achieve with chemotherapy combinations in relapse disease? You have different possibilities like fludarabine, RFCM, but I think, as said, it's quite toxic, not so much given RGMOX. You can give R-Benda. Yeah, BMR was an old regimen with mitoxantrone, but of course, bendamustine, mitoxantrone, rituximab. But as illustrated here, progression-free survival, median overall survival. This is not actually very, these are not very good data, of course. So this is why we are so glad to have targeted treatments in the relapse setting. And we have to state that ibrutinib has become a standard of treatment for relapsed mantle cell lymphoma. But these data show you that also ibrutinib depends on inferior prognostic markers or inferior clinical situations. Because when you look at the PFS one prior line or more than one prior line, you see that in the earlier disease course, ibrutinib is much more efficient than in later disease relapses. And this is true for PFS as well as for overall survival. So as effective ibrutinib is, it's more effective in the earlier lines. So the question, of course, is there still a role for chemotherapy in relapsed mantle cell lymphoma? And this was a study which was presented in Lugano 2 years ago. And what you see is quite interesting. So these are relapsed mantle cell lymphoma patients. Perhaps we focus here just on the progression-free survival. And you see that when patients relapse early, within the first 2 years after initial treatment, ibrutinib is substantially superior to different immunochemotherapies such as bendamustine or RBAC. However, when patients have a late relapse, so meaning that the duration of response is very long after initial immunochemotherapy, you see, at least in this retrospective analysis, that rituximab chemotherapy is still a valid treatment option compared also to ibrutinib. So meaning in a subset of patients where we have a long and good response to initial immunochemotherapy, it is possible to give still immunochemotherapy. And I will show you in a second a slide which also again shows you that our chemo is not over even in the relapse setting. So treatment selection in relapse, this is just summarize what I just said with some, with some animation. So which clinical setting or clinical situation favors the use of BTKIs? Most of them, short to medium time to relapse, insufficient response to chemo, other high-risk features, and you treat until progression, or you really use ibrutinib as a bridge to allo stem cell transplantation if indicated and patient suitable. And you know, this is the majority of the patients are unfortunately in this situation. But as said, when you have very late relapses, excellent responses to initial chemo, you could even use immunochemotherapy as shown before. So this slide shows you now the idea in the relapse setting. So we are now talking always about the relapse setting, how good actually chemotherapy-free approaches can be. We know from ibrutinib, it's a standard treatment, but the idea is to improve upon ibrutinib single agent. And this is why the Subparticle trial is important and a very important study, because it combines for the first time ibrutinib with Benito Clutch. We have this ramp-up phase, and then you give ibrutinib until disease progression. So these were relapsed refractory patients with mantle cell lymphoma, and you see here the response rates around 80% and the complete remissions between 60 and 70%. So very strong data for this chemotherapy-free combination. And actually the grade 3-4 events, they were manageable. There was no new toxicity signal, which we not know from Benito Clutch single agent or ibrutinib single agent. So as said, ibrutinib obeys still adverse prognostic factors. I think this at least we know for ibrutinib single agent. This is shown here. You have a higher risk of progression for PFS or for death when you have, for instance, the blasted history, as shown here, when you have bulky disease. So ibrutinib is not a wonder drug, a magic pill. It's an excellent drug, but has also difficulties in patients with a high-risk profile. And of course, the question is what to do with ibrutinib failures now in the relapse setting, when this is our standard treatment. And actually, this slide just shows you, because there was always some argument, arguments that might be when you use ibrutinib early on, that you spoil, let's say, your possibilities to salvage these patients compared to more conventional treatment. But this is not true. So because this is now the progression-free survival. So after relapse, so the patients got temsirolimus and they had their relapse and then they were salvaged. Or the patients had ibrutinib, had their relapse and they were salvaged. And this is the progression-free survival too. And you see that these patients who actually got ibrutinib, they have a longer progression-free survival too, compared to patients who were treated with temsirolimus. Why temsirolimus? Because it was approved for the treatment in relapsed follicular lymphoma. It was a large randomized trial, but you see, you should use ibrutinib also early on because it does not spoil your possibility to salvage. So the question is how to salvage. This was a nice presentation at EHA, and you see the patient number is small, but you can salvage. The response rate is difficult, around 30%, when you use different drugs. So there was assorted, so supportive care or rituximab or again immunochemotherapy. Also with lenalidomide, after ibrutinib, it's very problematic. Duration of response is short, response rate overall 30%. Benito Clutch is a possibility which we always would mention, and you see it's possible, but the data are not that strong. Yeah, the overall response rate 50% and the median progression-free survival of Benito Clutch single agent after ibrutinib failure is quite short. So what McCullough showed actually that when you give quite intense immunochemotherapy, of course, the patient has to be fit, RRC containing with RBAC, again, a limited number of patients, very encouraging overall response rates and the median PFS, which is not bad in this very difficult situation. So Benito Clutch is a possibility, but again, when your patient is fit enough, an RRC containing conventional immunochemotherapy. So what else? Which developments do we have, and are they important in particular for the situation where we have an ibrutinib failure in a relapsed patient with mantle cell lymphoma? And I think the non-covalent BTK inhibitor LOXO-305, I think these were, to my mind, nearly the most interesting data which we saw in last year's ASH, at least for mantle cell lymphoma and also for CLL, because what is very striking is, and you see here the waterfall plot, is that patients who were actually BTK exposed, they respond to LOXO-305. So these are the bright blue patients. So they were discontinued because of toxicity, not because of progression. But you see in dark blue that also patients who discontinued because of progression, they respond to LOXO-305. I think this is very interesting. We have to see, and there are larger trials ongoing now. But of course, this would imply that LOXO-305 would be also a treatment option for relapsed patients with mantle cell lymphoma after previous ibrutinib treatment. So which other developments do we have, and do they play a role? Yes, they do. Yeah, we have seen this very exciting concept to use CAR-Ts even first line within, of course, a clinical trial in ultra-risk patients with mantle cell lymphoma. But in relapsed patients, CAR-Ts are there now in mantle cell lymphoma. We have the ZUMA-2 study. And the ZUMA-2 study included patients who progressed after former BTK inhibitor treatment. This was the KITE product, the anti-CD19 CAR T-cell product, and it was a single-arm phase 2 multi-center international trial. And here are the data, and I think they changed the standard, let's say, in some way for eligible patients with ibrutinib failure. It was published very high in the New England Journal last year. And you see the overall response rate, but also the complete response rate with more between 60 and 70%. And the progression-free survival looks again very promising, some kind of plateau. It looks like overall survival, of course, we need longer follow-up, but really impressive data in this very difficult situation of ibrutinib failure in mantle cell lymphoma. So this was presented now at this year's EHA. Again, an update now focusing how well this CAR T-cell approach works in patients with early progression with POD24. And this is shown here. These are the patients with POD24. These are the patients without POD24. Of course, small patient numbers, but as it looks like also in POD24 patients, the CAR T-cell approach is very effective in inducing responses and also deep responses in the sense of complete remissions. When we go to the right, we see there is a trend to a lower progression-free survival, to lower duration of response and lower overall survival for patients with POD24 shown in blue. But nevertheless, I think we can state that also in patients with POD24, and what would be your alternatives, we have to say, CAR T-cell approach is more than justified. So this is also a presentation of this year's EHA, which compared in a retrospective way real-world data of patients with mantle cell lymphoma who relapsed after BTK inhibition, so after ibrutinib treatment, and they used certain, let's say, statistical methods to really match these 59 patients who were not treated with CAR T, but with the best possible choice, such as autologous stem cell transplantation and so on. With the ZUMA-2 patients in the clinical trial, what comes out is that whether you use unweighted or by the statistical method weighted Scholar 2 patients, and you compare the overall survival of these patients with the patients within the clinical trial, you see a tremendous difference. But of course, we have to be cautious. It's retrospective, and it's always a little bit difficult to do this kind of analysis. But nevertheless, it shows again that this CAR T-cell approach compared to standard of care is at, even when we are pessimistic, probably substantially better than what we had to offer the patients so far. So of course, it's an era of combinations. Now we have more and more possibilities. So I think the challenge will be how to sequence all these new treatment options and how to combine these different treatment options. And with this, I come to the end of my talk. So these are actually the German, Austrian, Swiss guidelines at the moment. So what do we do? I think it's in German, but I think it's easy to guide you through. So you have mantle cell lymphoma, asymptomatic, indolent. You see, we stay with watch and wait. So these are the most updated treatment guidelines for mantle cell lymphoma from our society. So, and only when these watch and wait patients get symptomatic, you start to treat. So when your patients have classical mantle cell lymphoma and you have a good ECOG, so they are fit, what you do when they are younger than 65 years, you give R-CHOP, R-DHAP. When they have a CR or PR, you give autologous stem cell transplantation followed by rituximab maintenance. When they do not respond, so where they have an early relapse or they are refractory, go for ibrutinib and discuss with the patient allogeneic stem cell transplantation. When they have a late relapse, as discussed, immunochemotherapy is still an option, or you can go for ibrutinib. And when we go up again for the elderly patients, use BR or R-CHOP followed by rituximab maintenance. And when they relapse later on, again, POD24, you see ibrutinib, late relapse immunochemotherapy, or ibrutinib. And in the ibrutinib failure patients, go for CAR-Ts. And you see here, we try to offer this the younger patients as well as the elderly patients. Again, this is more a treatment algorithm, let's say, what to do. Yeah, so at the beginning, you try to classify your patient into high risk or more low risk. And as illustrated here, for the high risk, our chemo plus BTKI plus X will be the future. For the high intermediate, it's probably the same, perhaps with rituximab. And you see here that CAR T cells will probably play a role already here, first line, at least in the ultra risk. What about the low intermediate? You omit chemotherapy, and depending on MRD positivity, you might use CAR T cells. And the MRD negative, you might stop treatment. And for the low risk mantle cell lymphomas, you go for watch and wait, or you use conventional treatment. So when I go back one, so this is where we are standing today. And this is where we might go into the future. Yeah, and you see our chemo perhaps by the most unfavorable patient group, but otherwise you will see that chemotherapy will disappear. And with this, I'm at the end. I think we discussed first the heterogeneity of mantle cell lymphoma, the standard of care for first line and relapsed, and we discussed the new developments for first line and relapse. But I think we all agree there's a lot of progress, and the future actually looks quite bright for our patients with mantle cell lymphoma. Thank you. Thank you very much.
Thank you, Prof. Bisuk. It's a nice and comprehensive presentation of a very difficult topic. Mantle cell lymphoma is becoming very complicated, the treatment with the many options that you have shown. So we have time for maybe a few questions, and I would like to ask all attendees if you can post your question in the Q&A and chat room. I will start with a question, Prof. Is there a place for ibrutinib in the first line? Which group of patients you will give ibrutinib in the first line treatment?
Yeah, I think that the trend and the development goes clearly for ibrutinib first line without any chemotherapy for the elderly transplant ineligible patients. Clearly a trend, and also for the low risk patients. At the moment, to use ibrutinib single agent first line in classical mantle cell lymphoma, or even in the low risk mantle cell lymphoma patients, is still experimental, we have to say. So we have all these good data I showed you, but we have to be cautious. As I showed, this was the first slide, mantle cell lymphoma is a very aggressive disease. And this is why we are very skeptical, at least at the moment, to omit chemotherapy first line in classical mantle cell lymphoma. I think we first need the trials I showed you before we would do this outside of clinical trials. But the trend is very clear for the low risk and for the elderly patients. It will come, I'm sure.
Another question, when we give ibrutinib, do we need to give rituximab always with ibrutinib, or is there studies showing that ibrutinib single agent can be?
Yes. So again, we have always to differentiate between all these clinical trials where you sometimes really lose the overview, and really the situation outside of clinical trials. And the standard for us is ibrutinib single agent. It's not with rituximab. We have the data for ibrutinib single agent. It's approved for relapse disease, and this is where we are using it. Whether rituximab really makes a difference, we don't know. We have, again, these single-arm phase 2 data in combination with rituximab. It might make sense also when we add venetoclax, even in a triple combination. But again, these are clinical studies. Outside, we would not add rituximab at the moment.
One last question. Any studies about acalabrutinib?
Yeah, so acalabrutinib, exactly. So there are two other BTK inhibitors, so acalabrutinib, zanubrutinib. So yes, acalabrutinib is active in mantle cell lymphoma. We have the feeling it's the same efficacy, so it's not inferior, but we also have the feeling it's not better. So from the efficacy, I think it's comparable, but what we also see in chronic lymphocytic leukemia, in Waldenström's macroglobulinemia, they have a different toxicity profile. And so the possibility is when you have a patient with mantle cell lymphoma and the patient has bleeding problems or cardiac toxicity, so Acala would be a great option in some way to personalize your BTK inhibitor treatment in mantle cell lymphoma.
Okay, Prof. I think we are running behind time, so thank you very much for this excellent presentation. And really we enjoyed it. And I would like to thank also all attendees and the sponsor of this meeting, Janssen. We would like to announce the next webinar will be after 2 weeks. So stay tuned until that time, and thank you everyone for attending this webinar.
Thanks a lot, and bye-bye. See you.